Welcome everybody, and I want to tell you that I'm happy that you are all here and will present the data of our HIPGEN project, which has run over the past 5 years now, where some very positive times and some hard times due to the epidemic that swept over the world, but we managed, and now we're here and we will present you our data. And with pleasure, I will immediately announce the first speaker of this public session. It's Matt Costa from Oxford. He's a professor of trauma surgery and a specialist also in hip fractures, especially. And I'm really looking forward to his 10 minutes of the medical need in hip fracture treatment. Thanks, Matt, for coming.
Great, so good morning everybody. Thank you very much, Tobias, and great pleasure to be with you this morning. So my remit was to really just do an introduction to why hip fracture and why do we need regenerative therapies in this area. So I have no conflicts related to any content in this talk. So you will all know this, but hip care is a huge problem for public finances, not just for patients. So in the UK, 1.4% of the total health and social care budget is spent looking after patients with hip fracture. It's around £2 billion a year in the UK alone. And that's a similar amount in many developed healthcare economies and a rapidly increasing amount in many low and middle income countries. Looking after patients with hip fracture is all about data and good quality data collection. Without data, we're lost. So in the UK, copying work from Scandinavia and elsewhere, we set up a hip fracture registry 16 years ago now, and we've been collecting data on all the hip fractures that happen in our country, 70,000 a year since that time. And by collecting high quality data and feeding that data back to the hospitals, to the clinicians looking after the patients, we've actually halved our mortality from 12% down to 6% at 30 days. As part of that, we've established some key performance indicators, quality standards for the delivery of care, including the need for early surgery, for multidisciplinary care, for early mobilization and so on. And we've been able to improve all the parameters across the board by collecting those data. The only outcome measure we measure, though, in the hip fracture registry is death. And is death the most important outcome? You might think that's a strange thing to say, because death is obviously quite important. But a patient, one of my patients in the clinical trial we ran, came to see me a few years back in the clinic. And he asked me, Matt, how did that trial go that you were doing? 2 different devices for treating a hip fracture. I said it was very interesting. We found some differences in the X-ray measurements and no difference in the number of patients who died. He said, that's very interesting, but I'm not interested in death. If I can't do the things I want to do in life, how long I live is not relevant. I'm 88 years old. And that stopped me in my tracks. I thought, well, if that's not the most important thing to patients, what is the most important thing to patients? So we stopped doing research in hip fracture for nearly 5 years and set up a project called somewhat grandly the World Hip Trauma Evaluation. And this was designed to really look at what patients think is important to them in their recovery after hip fracture, and can we measure these important factors in the context of a large-scale project such as a hip fracture registry. So we went right back to the beginning. We asked the patients and their carers, because many of the patients had cognitive impairment, what was their experience of having a hip fracture, and what was their expectation of their recovery. What we discovered surprised me, if not all of you. We found that there were some patients who were very active beforehand, but the great majority were very frail patients. Those that were active did anticipate returning to their pre-injury level of function. That was their goal. But the majority of patients did not expect to get back to their pre-injury level of function. Their hip fracture, for them, was part of their aging trajectory, and they recovered by adaptation to their new disability. They accepted that as part of their aging process. And completely threw me. I wasn't expecting that at all. So what did they tell us was important to them in their recovery? Well, top of the list was general mobility. Activities of daily living and self-care, very important for this group of patients. Anxiety was prominent, specifically the fear of further falls. I'd often thought as a hip fracture surgeon that I hadn't fixed the hip well enough if the patient didn't mobilize out of their home. But it turns out but they didn't mobilize out of their home because they were fear of falling again. Pain was on the list, but much further down than I expected. And death was there, but very near the bottom, actually. So it wasn't just one patient, it was most of the patients telling us that how long they lived was not the most important thing in their recovery. Top of the list, though, was mobility. And this is, of course, the issue for today. We looked at all of the outcome measures and tried to come to a consensus using the COMET methodology about what was important to measure for all patients after hip fracture, and came up with a core outcome set that's used now for all of the studies in the UK, and is available for use in other parts of the world as well. Mobility features very highly in that group. So where are we now? Just as an example, we've collected data from the UK on 27,000 patients with hip fracture who provided individual level consent for their data to be collected using the core outcome set. So what does this actually show? This graph, the vertical axis, shows a health utility scale. Some of you will be familiar with this. It measures health on a scale that's anchored at 0, being dead, a health state equivalent to death, up to 1 being perfect health. So you can measure everything from a heart attack to a hip fracture on the same scale. Patients before their hip fracture have a health-related quality of life utility index of just over half, so they're not fit and well patients beforehand. You all know this. Immediately after their hip fracture, they have a health-related quality of life that's worse than being dead. You might think, how is that possible? But if you're in the worst pain you've ever experienced, you can't move, you can't look after yourself, and you're frightened to death, if that was a permanent state of health, how many of us would want to carry on living in that state? So actually, it does make some sense. Now, of course, after surgery and so on, there's recovery up to 30 days, and then a little bit more recovery up to 4 months, but then it plateaus. And for most patients, that's the peak of their recovery. So what is this difference between their pre-injury level of quality of life and their post-injury level of quality of life? Well, there's a 20% permanent drop in quality of life. To put that into context, that's equivalent of having a moderate stroke or a new diagnosis of multiple sclerosis or Parkinson's. This is a huge permanent hit on patients' quality of life after one injury. So mobility is a key issue for patients in their recovery. But what do the patients think is the most important area for research? We've worked through something called the James Linderlines process, some of you will be familiar with, to work with patients and healthcare professionals to set priorities for research in the UK and beyond. We've asked lots of patients and their carers about their opinions on the most important research in this area. We collated over 1,000 research responses and filtered those and sifted through them to check which had been answered and which could be amalgamated. And through consensus methodology, we came down to a top 25 and then eventually published the top 10 priorities for research from the patient and healthcare point of view. What was the number one priority? So the thing that featured most highly for the patients in terms of their expectation of recovery was mobility, and the area thought that was most important to research was mobilization in the early period after their hip fracture. And of course, that's why we're here. That's why the HIPGEN study took place. Thank you very much.
Yeah, thanks a lot, Matt, for this very impressive talk that brings us back to where we started. And so hip fracture is a problem that is huge, and hip fracture is a problem of the patients. It's not a problem of the doctors. We can do a lot of stuff, but the patient has to profit. So I'm really happy to now tell Nitsan to come on stage and present from the Pluri, the sponsor of the trial and the partner in our consortium, the view on the product that we used, that we co-developed at the Charité and in Israel, and that we identified as being a possible option for patient with hip fracture. Nitsan, thank you.
Thanks, Tobias. Good morning, everyone. So I'd like to use the next 10 minutes or less to really give you a highlight of the product, what it is and how it was used in the context of this study. I won't go too much into the mechanism of action because that would be covered later in the day by Ornella. So Pluri is a cell company, but what we're talking about today specifically are cell therapies. We make cell therapies from placental cells in our in-house GMP facility. These are allogeneic products that have a long shelf life. They're provided by a simple IM administration, specifically here to the muscle right after surgery. And they work by secreting cytokines systemically that help regenerate muscle function and reduce inflammation. As I said, we produce the cells in our in-house GMP facility in Israel, in Haifa. We have multiple patents that cover our technology. Cells are produced in bioreactors in a very consistent procedure with batch-to-batch consistency and not a lot of variability. Our factory is GMP certified, and our process has been approved by multiple regulatory agencies. I'd like to invite Maya Zorea, who's our logistics operations manager, to talk a little bit about the logistics of how do you transfer a product like this across the globe. Maya? Is supposed to be online? No? Is there someone online who's supposed to be speaking now? Are they muted? Maybe?
Anyone hear me?
We can hear you now.
Oh, great. Hi. So hi, everyone. My name is Maya. I'm the logistics manager, as Nitzan mentioned. Just a short recap on the logistics that was done here in this trial. So basically, as you can see, our product comes in these small vials that you can see in on the slide, which had to be in very low temperature, below minus 150 degrees Celsius. So the entire time they were placed inside liquid nitrogen tanks, either at Pluristem or in the depot. And when we had to send them out from Pluristem to the sites, we had to use these dry shippers, liquid nitrogen dry shippers, where we place the vials inside. We make sure they're sealed, the inner shipper and outer case that you can see here. Both are sealed with two inner and outer seal to make sure no one opens the shipper during the way. And then a data logger is placed on top of the inner shipper and is being turned on to make sure that the entire shipment is being monitored. You can see the graph here that shows that the temperature was below minus 150 degrees the entire time until it reaches the destination. Now, the main issue at the beginning of the trial was to decide how the logistics is going to work. Before starting the HIP, the idea was to use a central depot, which obviously had many advantages. We had a local depot in the US and in Europe, so it was close to the sites that were performing the treatments. It was very easy to manage the inventory there because we had only one place in Europe and one place in the US that kept our product. So our planning department had a pretty easy job to monitor our vials. And obviously, we performed an audit before starting the trial, so the depots were very well trained by us. So it was obviously quality approved that they know the procedure and they can go ahead with the trial. However, that meant that the product is kept in these hubs, and then every treatment we had to send a shipper from the depot to the sites in its territory to make sure it arrives on time. And then we decided to start a new alternative, which was to keep the product in the sites themselves. And that made it very easy for the sites because they didn't have to rely on any shipment. They just had the vials at their own location. However, we had to manage many sites, and the planning of the inventory was much more complex than the hub ones. And obviously quality was also could have been compromised because we had to train and perform audits to many different sites with many people to be trained. So it was it's much more difficult quality-wise. And we actually decided at the end to use these two options, kind of a hybrid solution, to make sure that some of the sites prefer to use with a depot, while the others prefer to keep the storage at their location, which was easier for them. I think this captures basically everything.
And just before we close off, I want to really briefly tell you about the cells, PLX-PAD, as I said, placental expanded cells. I won't go into too much detail, as I said, because there is a session in the afternoon, but in general, the cells are injected right after the surgery into the muscle after it's sewed back together. And what they basically do, as you can see on the right-hand side of this slide, is they produce several cytokines of various functions in the body. We do believe that they reside in the body for up to 4 weeks and are active, but their long-term regenerative effect is what we wanted to explore in this study, and I'll be happy to share with you in the next session, actually, what we saw.
Yeah, thank you, Nitzan. Nitzan Halevi is the Chief Medical Officer of Pluri. The actually information that you can draw out of this presentation is how huge the logistical task was actually in this whole consortium. And it was really well managed as we had, for example, possibilities when I think about Oxford now to also cycle the containers because the cells always need to be on minus 196 degrees, and you have to permanently assure that this chain is also provided. But with the logistic knowledge that we gained also throughout this trial and also other trials that have been led, we can say that we could provide really a very, very robust chain, and we did not have an issue, I think, actually, with including one patient due to the logistics. So thank you very much to the logistics team here. So let me talk about the study, the core of the whole consortium. It's the HIPGEN clinical study. The HIPGEN is a synonym for us. It's quite, it's in our mind, so we did not. Maybe somebody or everybody does not remember how it was created. It's hip regeneration. So this we wanted to brand, and also with the help of Alta and of Inacta later, we had then this nice branding that you can see here, which is maybe also for the ones who weren't there in the start, should be a proximal femur and the gluteus muscle in the P. Maybe you can acknowledge that what we branded here, because this was also a lot of thinking going into that. So what was the rationale of the whole study? Not of the brand now, but of the whole study. In total hip arthroplasty and also in partial hip arthroplasty, you always have muscle damage. No matter what the surgeon does, if the surgeon uses this approach, that approach, you always either have to dissect the muscle or to crush a muscle, because for the duration of the surgery, you have to expose the joint. There is no way of not exposing a joint when you want to implant a hip stem, and in case of a total hip arthroplasty, also a cup. And what you can see here is to the left side, a total hip in the bone. But the bone is, of course, surrounded by muscle, which is shown in the third picture. This is an MRI, and on the left side, seen from the patient, you can see marked by arrows here a degenerated gluteus muscle, traumatized, and on the right side from the patient, you can see a healthy muscle. We did some histology on these muscles, and we saw that you had a tremendous impact on the muscle microstructure also, and this was a problem in a lot of patients actually, and as said, in all patients there is a certain damage of this muscle. So we definitely needed new supportive therapeutic options. The PLX cells that you were already introduced to are cells that come from human placenta. So from the decidua, this is the maternal side of the placenta, and they are cultivated in 2D, then in 3D later, to be little biofactories. And these little biofactories produce, with its secretome, immunomodulating factors, anti-apoptotic factors, which is cell death, programmed cell death, angiogenetic factors, so the production of new vessels, and also, as depicted here, they improve myoblast migrations, all of which, if taken into context with a very busy slide that Nitzan showed you before, with all the secretome also and its effects depicted, promoting muscle regeneration. In our initial trial, this was a preclinical trial, it's not this phase 1-2, but it's our preclinical trial. We injected these cells after several rounds also of autologous mesenchymal stromal cells into a preclinical model of a muscle injury, and we saw a tremendous increase in muscle force. This was actually then the point where we said, okay, we have a very good cell therapy, we have a model, and we have a proof of concept, a preclinical, so we go into a phase 1-2. This phase 1-2 was a randomized double-blind placebo-controlled trial that we did at the Charité in Berlin. We included 20 patients between 50 and 75 years, and these patients were receiving an elective total hip arthroplasty, meaning elective that they were scheduled for a surgery. So they had a hip osteoarthritis. This is a degenerative disease of the hip. And therefore, they were scheduled for arthroplasty as a solution to the problem. The other problem, the muscle injury, was tackled by injecting either 150 or 300 million PLX cells, placental-derived stromal cells, or placebo. After surgery, how this is depicted in the picture here, we made 10 injections in total on each side of the incision. The efficacy endpoints were the change in gluteus medius strength at 6 months, and also the change in gluteus medius volume at 6 months. Keep these endpoints in your mind. And the study length was 2 years for follow-up and 6 months for efficacy. What we saw reflected exactly what we saw in the animal studies and in the preclinical studies. We saw an increase in muscle volume. Here you can see the placebo group, so patients who did not receive cells, as a blue line to the left. In the dark green, this is the 300 million cells group, and the 150 million cells group, the effective cells group, can be seen as light green. And to the left, you can see that we saw an increase in muscle volume, and this increase in muscle volume, we also did histology again on these patients, was not because the muscle had an edema or fatty degeneration, but it was really muscle substance. This was then reflected also in an increase in muscle strength at the injected site, also to a certain extent at the contralateral, the other side. At the injected site, you can see there was a very good effect of the cells after 26 weeks, so half a year at this at our primary endpoint, that clearly differentiated from placebo in the middle, in the blue. We also saw the effect in the contralateral side. This might be a training effect, I have to admit, because if you improve one side, you always also have the other side having to do the same stuff like the treated side, of course. So we cannot exclude that. However, if we looked into the systemic, into the system of the patients, which is the blood, we saw that we could correlate this with a reduction of postoperative stress-related immunological changes. This was the work of Dieter Volk. At the Charité, we could see in different cellular factors and humoral factors that this postoperative stress was almost abolished here by the cell therapy. This then told us that we had an effective therapy, we had a systemic effect, and this effect is also reducing immunological stress. So we switched the indication now from an osteoarthritic elective model to a more of an emergency type of model, femoral neck fractures, which means a specific type of hip fractures. And this you have already heard from Matt, I do not need to repeat it, is an increasing problem because we are getting older. And this getting older comes with a price, and this getting older has to be, is one of the major problems that we see now in our society, and this getting older has to be accompanied. And we as doctors want to accompany that and provide a better, longer life, because not only prolonging life is not the solution to that. We already heard about that. In femoral neck fractures, we do surgically everything actually what we can do, and actually the patient should be able to mobilize immediately. But due to several reasons, as laid out by Matt, they do not. And one is the muscle trauma that they have on top of the damage predisposing sarcopenia. So these patients have already lower muscle mass because they are elderly. And then they also occur or run into this surgical stress, which also leads to the high mortality that we saw. That almost also meets in some patients or in some patient collectives cancer values. So the study objective was to show safety and efficacy of the PLX cells in hip fracture muscle recovery. We had to go for a primary endpoint because a phase 3 study always needs an endpoint that is translating actually in some way into the clinical perspective, which we then decided to use the short physical performance battery for. The short physical performance battery is a quite complex actually endpoint, which is a balance test. So which means the ability to sight in normal, semi-tandem and tandem, which is depicted by these feet that are here on the slide. Then we have a 4-meter gait speed test, the time to walk 4 meters, and the 5-chair stance test. So this is the time a person can stand up from their chair 5 times. You can try it if you want, but it's quite a hard task actually also in the morning for you now, I suppose. But for an 80-year-old lady after hip fracture, you can imagine that this is quite a hard task. So an endpoint composition that is quite complex. The study design is depicted here. We had a placebo arm, and we of course used the most effective treatment arm and treatment dose that we had, the 150 million cells, which was injected after surgery. It was of course fully blinded, and we are still blinded. So what you will see here is data that has already been unblinded to a certain group of people who are not dealing with the patient. So myself, as the principal investigator, I'm fully blinded, and we are not able to show all of the data also because of this blinding that is still going on. We already reached the primary endpoint, and the week 52 endpoint is yet to come for some patients, after which the unblinding will occur. The first patient in was on August 5th in 2018. That was quite a celebration when we managed this, because until then you have to do a lot of regulatory stuff also to get your study aligned and the consortium aligned. And the last patient in, we were happy to have at the Charité. Of course, with 20 clinical sites, this is quite by coincidence, but it was, a nice side fact maybe. It was on the 11th of November in 21. So, I now hand over to the HIPGEN team, I think. And please, all the speakers online, please also activate your camera, otherwise we can't see you on the slide. Thank you.
Okay, hello everyone. Can you hear me? Hello. My name is Vera Degtyaryova. I'm the project manager from HIPGEN. I will present to you a few slides. So on these slides, you could see the status of sites in the study. 23 sites have been activated, and among those we have 11 sites which are still active and open, and 12 sites which have been already closed. We recently have closed 2 sites in Israel, 2 sites in the US, and 1 in the UK, since there were no ongoing patients at these sites, and we have closed these sites after the soft lock. Please, next slide. Next one, please. Yes, thank you. At this slide, you could see the recruitment. Recruitment has started in August 2018. Yeah.
Thank you. We see it now.
So may I continue? All is fine?
May I suggest something?
Sure.
May I suggest that we start the presentation of Vera again with a slide? Mm-hmm. Yeah.
Okay.
Okay.
Yeah.
And if this is the camera position and the picture, I would say that we do the following. Exactly. We show me. Yeah. Super. But no, I would suggest that we show Vera in the beginning, in the picture, and then we go to the full slide and do not show Vera again, because Vera, we do not see the slide very large with
my
you.
face.
Okay.
Yeah.
And then we cut this for the public. Okay.
Okay. So then please go back.
So Vera, yeah, we give you a sign, and then please start again with your part of the. I would start from the last slide already.
Okay.
Okay.
Yes.
One moment. Yeah. Okay. Mm-hmm. No, I get a no.
No. Yeah, I can start, right?
One moment.
Okay, waiting.
I got a no from Gabriela, and no is over no here. Yeah, you control it, you mean? Yeah. Okay, so tell me when Vera can start. I will control the slides, that's not a problem. Yeah, of course. No, I can. Okay, Vera, thank you. Please start.
Yes. So at this slide, you can see the status of sites in the study. 23 sites have been activated, and among those we have 11 sites which are still active and still open, and we have closed 12 sites. Recently, we closed sites in Israel, US, and the UK. At these sites, we had no ongoing patients, and we have closed sites after the soft lock. Next slide, please. This slide presents the actual recruitment timelines in the study. So recruitment started in August 2018 and closed in November 21. For sure, the recruitment was affected by COVID, mostly in March, April, May 2020. And in total, the recruitment actually took 3 years and 3 months. And I would say that the last patient has been randomized at Professor Tobias Winkler's site. The last patient was randomized on the 12th of November last year. Here you can see the split of countries with the recruitment. You could see that Israel was on the first actually place. In Israel, the 99 patients have been randomized. On the second place, Germany with 59 patients randomized, and in the US, 43 patients. Here you could see the status of patients per country in the current moment. So you could see that we still have 6 ongoing patients. Actually, we have 1 ongoing patient in Bulgaria. And for this patient, we expect that week 52 visit to be done in October. And there are 5 patients, ongoing patients in Germany. Among those, 3 patients to be contacted to perform the safety call. Following the announcement of early termination, patients could not be reached yet, but still we plan the site to complete the safety calls. And also 2 patients in Germany for whom a week 52 visit to be done. We expect that the last visit in Germany, it will be the last patient last visit in the study, will be done on the 19th of October. Also, you could see the figures, yes, of patients completed 91 and early terminated. Yes, you can move to the next slide. Presenting the number of completed patients, early terminated patients following the announcement of the study early termination. And also Alona is going to present some data about that. And also you could see the split of patients, early terminated patients due to different reasons. You could see that most of patients among this part are patients who withdrawn consent, patients who were lost to follow-up, death, and this is 11 cases, in most of cases, patients who were early terminated due to COVID. And another reason was the PI decision when patients were not able to continue the study treatment. Yeah, thank you. So I hand over here at this stage.
Yeah. Thanks so much, Val. So briefly to just show you the disposition of patients, and again, I remind you, this study is still ongoing, as Tobias mentioned, and Vera as well. So all the data that will be shared here is not anything that could be unblinding on a patient level, but only group level data, and really no country data at all, which may be unblinding since some countries, as you saw, only recruited a small number of patients. So overall, we screened 249 patients and randomized 240. That's a fairly good rate for a multi-center trial. We only had 9 screen fails. And we were able to treat almost all the patients, 233. Several were not treated because the surgery got delayed and then they were no longer eligible or for other reasons. But mostly, I think, overall very good rates of screen fails and randomized not treated patients. Of course, when we analyze this study, this is a phase 3 study, so according to our statistical analysis plan, any patient that was randomized will be used in the study analysis. Their data would be used. And so we, as I said, randomized 120 patients for PLX, PAD, and placebo. Of those, really, we had a high discontinuation rate. This is an elderly population, so going into the study, a certain rate of dropout was anticipated. But because of COVID, this discontinuation rate reached 30%, which is fairly high, and obviously impacts the quality of the data, because when you have a lot of patients who don't complete the primary analysis or the primary endpoint visit, you have to impute the data for these patients, and that obviously is something that we need to consider when we look at these results. The most common reason for subjects not reaching the primary endpoint was they just withdrew consent. Coming into the hospital, especially during COVID, was very hard for these patients who were frail, elderly, and they just didn't want to come anymore. So 15% or 14.6% were discontinued because of withdraw consent from the subjects. Just at a high level, I'd like to take you through what was our patient population. So the mean age was 77, well balanced between the 2 treatment arms. We had more females than males, not surprisingly. This is something that's known about this indication. So 70% females, mostly white. Maybe I can't do the pointer, but mostly Caucasian, mostly white. 90%. And again, this, I think, points to where we recruited patients in this study. And for the type of planned surgery, it's a hemi or a total hip arthroplasty. It was fairly well balanced, with most patients undergoing a total hip arthroplasty, about 60% in both treatment arms. The one area where we showed slight imbalance between the two treatment groups was the levels of myoglobin right after surgery. This was slightly higher. You see in the severe group here that's circled in red, slightly higher proportion of patients in the treated group that had what we decided to call severe muscle injury at the time of surgery than the placebo patients. The patients were well balanced on baseline hand grip strength, which is thought to be a measure of overall strength in the body. The type of fixation, again, well balanced, with 30% having a cemented surgery and 70% having a cementless. And you see here the classification, the Garden classification, showing the type of fracture, and again, very well balanced between the two treatment arms. So overall, randomization worked. We got a very balanced population that is reflective of patients undergoing hip replacement surgery. I think we'll skip this and do the detailed analysis in the afternoon session. But in general, as I said, because there were a lot of patients who were lost to follow-up or had to have home visits instead of the planned clinic visits, we had a lot of missing data for the primary endpoint. So the primary endpoint, as Tobias mentioned earlier in the talk, was the short physical performance battery, or SPPB, at week 26. And for this, you need to be in the clinic when patients had a home visit or a phone visit for COVID reasons, and they couldn't come in. Obviously, even if they were still in the study, we didn't have a result. And again, we used multi-imputation to really give them a value. So the primary endpoint for the study was not met. You see here that really the curves for PLX, PAD, and placebo overlap. There is no difference between the treated and non-treated patients at any time point for SPPB. And the result is fairly, what we're seeing here is the number, the score of 6 or 7 is really reflective of poor function for these patients based on the literature around SPPB. What we were able to see, which was quite exciting for us, is really that we were able to demonstrate, similar to the phase 1/2 study that Tobias presented, an improvement in hip abduction strength from week 6, which is the earliest time point, where this could be measured post-surgery, to week 26. This was in the injured leg, where the surgery was done and a drug was injected, as you see to the left, but also in the uninjured leg, again, very similar to what we saw in the phase 1/2. And if you try and look at these in parallel, you have the phase 1/2 results at the top and the phase 3 results on the bottom. You really see that the impact is kind of similar. Injured leg to the left and injured leg to the right. And you see here that there is definitely something that is repetitive, which to me is reassuring that the effect of the drug is real on muscle strength. I'd like to invite Sonia to give you a little bit of a flavor on an interesting and innovative measurement of mobility.
Thank you, Nitzan. Good morning, everybody. So now I would like to talk about instrumented insoles. So it's a very specific tool that we have here in this test. And the main purpose of this assessment is to objectively measure the preferential weight bearing and also the load asymmetry. The participants performed a modified version of the main primary outcome, the SPPB, as tolerated. We have done this at multiple time points. Initially was at day 5, so the patient was still in the hospital, so this was an inpatient follow-up visit. And here, as the patient was still in a very fragile status, we only asked them to stand comfortably as they could. Then we repeated the tests at week 6, 12, 26, and 52, and this time was at outpatient follow-up visit, so the patient had to come again to the clinic and perform these 4 tests, of course as tolerated, so the standing comfortably, the standing evenly, overground walking, and sit to stand to sit. But what these insoles do actually, so they have a very large sensor that covers the entire surface of the insole, and they acquire the plantar loading, so the vertical force when you touch the ground as a response from the ground. Here I would like to show a movie, so if you guys could also hit play. No? Otherwise, you will have trust in my words. So what we could see here is that the subject has the insole in the shoes, inside the shoes, so we use the insoles inside the shoes, and the forces are to 0. So no, they don't touch the ground, so no forces. As soon as the subject starts to touch the ground, we can see that the forces go up. And when the subject starts to walk, the forces will also have another dynamic pattern. And later I would also have used here a crutch, so we could see also that the forces on the opposite side from the crutch. So if I had the crutch on my left side, on my right side, that I was supporting the left side, so the left force will be reduced compared to the right. So that we can also have a measure of asymmetry, so side-to-side differences. How does it work here in the HIPGEN study? So we have distributed all of the sites from the insoles across all of the sites that we have included here. We also have developed a dedicated application to facilitate data collection among the sites. And here, of course, we also have to perform the tests with the subjects. Each site was properly trained and also multiples trained after the initial training, and they collected the data at each site, and then to centralize the data collection and all of these processes, we have included in the application, in the iOS application, also a feature that could bring all of the data directly and in an easy way to our servers, where we then were able to start the local data analysis. So this is just small examples of the extended analysis of the walking data, still blinded. And here what we can see on the y-axis is the VUSI, which is a measure of asymmetry, so the side-to-side difference during the walking. On the x-axis, we have the different phases from the stance phase, so from the heel strike until the toe off. And when we see a negative value, this indicates that the subject is loading more the non-operated side. What we can see here is that over time, so week 6, the orange color, they appear to have the largest asymmetry, so they rely less on their operated side, and this goes, they are relying more and more over time on their operated side. What is really interesting from this data is that if we just focus on the first 25% of the stance phase, so when the subject is applying the load to the leading limb to initiate the gait cycle, is where we see the largest asymmetries and also the largest improvements during this cycle. And this is called weight acceptance period, and in terms of biomechanics, this is a very important period because it's when the hip abductors, so the gluteal muscles, are mostly active. So we are very curious to see if we can see any effect from the treatment on this specific period. So this was all. Thank you so much for your attention, and now I give back to Tobias.
So thank you very much. I think we have time for a very short break until 10:25. Break. And we jump into the second part of the public session of our HIPGEN final meeting. And I'm really curious and thrilled about the presentation of Guido Moll from the Charité. He will talk about the work package biomarkers.
Hello. Thank you so much for giving me the opportunity to present the biomarker work package of the HIPGEN study. I would like to thank very much Hans-Dieter Volk, Peter Reinke, and the biomarker study team, and also all the clinical centers for the excellent cooperation and contribution on this work package. Next, please. So here a short overview of why biomarker analysis is important. for clinical studies. We have the unique opportunity that we have a placebo-controlled randomized study where we can compare treatment, patients treated with PLX-PAD versus placebo-treated patients. So according to the quality of evidence scheme, we have very high evidence, if we see differences here, that this is a good proof of biological activity of our product, cell product. We can draw several conclusions from this analysis on the safety, the pharmacokinetics, and the pharmacodynamics of the product in patients, which can also be interesting for stratification of patients in future studies. So considering safety, for example, immunogenicity, hypersensitivity, or over-immunosuppression can be analyzed by looking into the biomarkers, or cytokine release syndrome, which is important for some T-cell studies, or has been important for some T-cell studies. And next slide, please. So this work package looked at 4 different tasks or deliverables. First of all, the immune cell composition, which was analyzed with flow cytometry and using a duraclone, and also monocytic HLA-DR expression. Then immune cell functionality, which was analyzed by cytokine analysis with mesoscale, and also by stimulating patient-derived blood cells with LPS and CORNA in whole blood assays. Third, we looked at the molecular signature of the patients by conducting RNA-seq transcriptome analysis with the novel seq platform on patient-derived blood cells, which was accompanied by bioinformatic analysis of the next-generation sequencing data by Carsten Juchot. And the fourth part of our work package was to study the alloantigen response by using ELISpot technology to look at the alloreactivity of the cells, and anti-HLA Luminex platform from the HLA lab in collaboration with Niels Lachmann to look at patient antibody levels. Next slide, please. For the analysis of these biomarkers, the logistics are of high importance. So first of all, as you can see on the left, the biosample availability is crucial. So we need to make sure to get enough samples from the clinical sites, and that the patient screening recruitment works effectively, that the study visit compliance is high, that we get good kinetics, and also the timing and the quality of shipping the samples is important. So that leads over to the sample transport, biobanking and analysis, which was handled by HIPGEN and our study lab at BCRT. And we need to anticipate if we analyze fresh samples or have to subject them to cold storage or intermediate storage. So temperature is a very important aspect. And then also to actually conduct validated biomarker analysis with validated panels. And the third point is the archiving and bioinformatics and statistics, where our team uses a certified LIMS system called LibVantage to document all the patient samples. This is done GLP compliant and integrated in a database of patient study data, and which allows us to generate patient cohort data. So altogether, this is a huge team effort from clinical teams to the logistics part, to the analysis team, which involves a lot of people. And what's most important is to have a seamless integration of the different working steps to actually get high quality data that allow proper conclusions. Next slide, please. Next slide, yeah. So here you can see the first step was actually to design the lab manual to have proper instructions for the study teams. So this effort took over a year and 7 iterative revisions of the sampling instructions for the lab manual production. So we had to check this many times again and again and again to eventually come to a point where the instructions were sufficiently done to allow for the successful shipping and analysis of the samples. And the lab manual version 3 that was sent to the clinical sites was eventually produced on June 5th, 2019. And then in the subsequent 3 years, the patients were included and followed up to now allow for the analysis of the samples. Next slide, please. So here you see an overview of anticipated versus received samples. So when we started the study, we estimated how many samples we would get from the different centers, and especially how many biomarker patients we would get to actually conduct a successful analysis in the end, to estimate based on power analysis how many data we could get in the ideal case to work with at the end. And on the left side, you see the different centers, and on the top, the different tests, and in brackets, the estimated patient numbers, and below what was actually achieved. So we see that our 2 centers in Berlin recruited almost as many patients as anticipated. And we also got very good data out of it. And in addition, also Dresden site performed much better than originally thought. Than anticipated. Oxford, we were successful. Yeah, I'm still okay. Next slide, please. Next slide, please. Here you see the actual result. Oh, sorry. Can you go back, please? Can you go back, please? One slide. Yeah. So here you see what we have to work with. So this is the samples, a quick overview of the samples that we actually received for the duraclone analysis and cytokine analysis. So it's sorted according to different centers and patients and the tests obtained. And we got around 50 patients, 50 to 60 patients for half of the test, and for the other one around 20 to 30 patients, which was enough for analysis. And here you see also an overview on the RNA-seq, just to give you an idea how this looks like. Next slide, please. So this is a brief introduction to the duraclone flow cytometry panel. So this is the validated flow cytometry panel based on duraclone technology, which consists of dried antibodies in a fax tube with customized drop-ins that the patient blood is added to. And we can, in a modular fashion, change the content of the panel by adding different subsets of interest. And this will then yield a highly standardized analysis over time that allows actually to analyze the kinetics of immune cells in the blood of patients and their interpretation for pharmacodynamics and also for future stratification. Next slide, please. Next slide, please. One of these markers that is of high interest is monocytic HLA-DR expression, which is the immunocompetence marker, and that can be used to see if we have over-immunosuppression or a faster recovery of immune function in patients. And yeah. So that was found to be of interest in the prior studies, and I will go into detail when showing the data. Next slide, please. So here you see the first blinded results that we presented in March 2020 at the last annual meeting. And what we found in the blinded fashion is that the neutrophils show a typical fracture surgery therapy induced changes. So they are elevated at screening and day one and then drop to similar the leukocytes. And so altogether, we see very robust kinetics and some markers that might be of interest are the CD4, CD8 ratio, monocytic LGADR expression. So next slide, please. So here you can see some first unblinded results from September 2022. So you see that both treatment and placebo group have very similar kinetics regarding the neutrophils and also the leukocytes. So they're very much comparable. So are the other different subsets. So all this speaks for the safety of the treatment. So we don't see any dramatic changes in certain immune cells. And we confirm the fracture surgery therapy induced changes. Next slide, please. And here you see that actually some of the cell types show differences according to cell treatment or placebo, such as monocytes, and particularly classical monocytes. And also for HLA-DR, you see that there's a separation of the groups at day 1 to week 12 of treatment, which is of interest considering reconstitution of the immune function. Next slide, please. When we look at the statistical evaluation and look at all the data, we see no significant differences, however, for the absolute measurements and the measurement per cell of HLA-DR. But when we look at the individual profiles, we see actually that we have a lot of incomplete patient profiles in the week 12. And that there seems to be a clear separation between placebo and treatment. So we instead looked at complete cases only, so only patients where we have complete kinetics over time, and see that there was an improvement of the p-value for PLX-PAD versus placebo. And important here is to say that these are preliminary data, so they are currently in the QC of the study team, where they check every individual value according to their quality metrics and to log it in the database. So we hope that we get additional measurements for some of the time points that will, in the end, improve this whole picture here. Next slide, please. In addition, we did the cytokine analysis, the level 3.2 with mesoscale and ELA system. Next slide, please. So here you see the blinded results for March 2022, where we saw some interesting modulation over time in factors like IL-10, IL-6, and I will only in the next slide show the patient plasma cytokines, not the other two tests, just to have a first glimpse. Next slide, please. So here are the unblinded data for the patient plasma cytokines assessed with mesoscale. So we actually have a quite significant difference in the kinetics of IL-6 and IL-12, P70. And we have a trend for differences in IL-10, IL-4, IL-8, and TNF, especially at day 1, here at day 1, at day 1. So, and for some also in the later time course at week 12. So altogether, that looks very interesting and appears to indicate biological activity of the cells in patients. Next slide, please. Here's some the still blinded results that were presented in March. So we did a principal component analysis of the 1,000 top variable genes, and we found a strong clustering according to patients or subjects, but not to visits. So there's lots of heterogeneity in the patients, which overrules that of the study visits. And we also analyzed back then some potential confounders, such as batch effects of the analysis rounds, of the technical rounds of the NovaSeq runs, or potential confounders due to the variation of the study centers, center effect. And we found, when we looked at the gene ontology analysis, some modulation and biological processes related to stress, immune system response, immune response. So altogether, many pathways involved in that were indicated in the mechanism of action of PLX-PAD cells previously. And next slide, please. So we did now a first preliminary unblinded analysis of the first 3 runs, NovaSeq runs. The 4th one is just running right now. So it will be complete in the next couple of weeks, all 4 runs, which will give us in total around 70 patients with complete visits 1, 2, and 3. So you see it got more busy due to the extra patients that are now included. And we see a strong clustering once more for the first 50 patients according to the patients, but not visit or treatment. And we are currently checking for multiple confounders, again, just such as analysis runs, country effect and center effect, where we see some minor variability, for example, when comparing patients from Israel and Germany, which are the 2 largest groups. And yeah, we did, in addition to the all-in analysis of all the patients combined, we also did sub-stratified analysis comparing, looking only at patients from Israel or Germany to see if we see some impact there, and we also control for gender. And we do not see a strong impact of technical analysis rounds, so that speaks for the quality of the analysis. And the analysis of differentially expressed genes is very challenging due to the high donor variation. So we, our bioinformatician, Carsten Juchert, chose 2 different approaches here to either compare placebo versus PAD for the different visits all in, or instead looking at the different visits within the 2 treatment groups and then comparing these afterwards with each other. So this is a very sophisticated analysis that Carsten is doing. He wrote me in a 4-page summary in Word, and this is just a wrap up of the stuff that's ongoing here right now. Next slide, please. So in conclusion, for the biomarkers, these are important for interpreting the safety, efficacy, pharmacokinetics, dynamics, and mechanism of action of cell therapies such as PLX-PAD. And we have now obtained the data for all of the patients, and around 50 to 100% of the originally anticipated biomarker samples. So for some biomarkers, we have less samples that we originally anticipated, but that's what we have to live with. And we are currently analyzing the data. We have done a partial unblinding of our analysis team. So the data evaluation is still ongoing. This is just a preliminary analysis that we were showing here. The final quality control is still ongoing. And we also want to conduct responder analysis for full, partial, non-responder, and more analysis considering the impact of gender. And here you see a short basic summary of the 4 different major tests, what the preliminary results indicate. So overall, we have very robust kinetics and typical fracture surgery and therapy induced changes in leukocyte and neutrophils with the Duraclone. We see some modulation of CD4-CD8 ratio and monocytic HLA-DR with large inter-individual heterogeneity at some visits. And also some indications for even statistically relevant indications of differences of subsets, certain subsets between treatment versus placebo. Considering cytokines, once more we see very robust kinetics and typical fracture surgery therapy induced changes and inter-individual heterogeneity for some markers such as IL-10, IL-6, and in part also interferon gamma TNF alpha, with an inverse relationship between in vivo and ex vivo data that we have not shown here today. And considering RNA-seq, we see variability in patients that is larger than in the visits. And we see a typical gene modulation as expected in the fracture surgery therapy setting. And the in-depth analysis of comparison of treatment versus placebo is still ongoing. And I haven't shown ELISpot or HLA data yet in this open talk, but we see no significant increase in cellular allo-response to PLX-PAT analysis or no indications so far of a change in humoral markers. And this will be revealed in the next month when we finalize this analysis. Next slide, please. Next slide, please. Yeah. In the end, I would like to thank all the people that were involved in this work package, particularly Professor Volk and Professor Reinke for conceiving this analysis and for establishing this analysis and building this team together with the study lab and bioinformaticians. And it has been super interesting to look at this and this placebo-controlled randomized study to actually get some solid proof, I would say, of biological activity of MSCs in patients. Thank you so much.
Yeah, thanks a lot, Guido. I think Guido receives the award for the most granular slides of the meeting, definitely already. Thank you very much. So I'm really looking forward to jump into this data and to talk about this data in detail. Looks very promising, but we have to digest this now, I think. A lot of data. Now comes also a lot of data, and I'm happy to present you Ornella from Brescia in Rome. Ornella Parolini is professor there, and she is a specialist for placental and amniotic cells, and I'm happy to hear her talk.
Good morning, everyone. It's a great pleasure, actually, to be here. Thank you, Tobias. Thank you to all the consortium for the possibility to collaborate in this very interesting project. When you are somebody that is working in a lab, you always like to see whatever you do, which then reflects on the patient. So that's a great opportunity, this type of project. So the presentation actually is divided between my presentation and the one of Sven that will follow. And actually we will underline which are the mechanism of action of placenta in the muscle regeneration. And I will focus mainly on the tissue regeneration associated to the modulation of inflammation. And then we will hear the presentation instead about the effect of these cells, their action directly on myogenic cells. So in order to understand the mechanism, whenever we are trying to think how we can cure a disease, I think the first thing we need to do is to try to understand what's going on at that moment in this disease. So even though the slide is very complex, probably, but the message is very clear. So whenever we have a muscle trauma, it's actually... some more time with the pointer. Whenever we have a muscle trauma, we are going to have the release of the so-called damage-associated molecular patterns molecules. They are going to somehow foster the inflammation due to the recruitment of different inflammatory cells like T cells, monocytes, neutrophils. These ones are going to release a bunch of cytokine, so inducing a strong inflammatory milieu. And actually, this is relevant. This is the first phase of inflammation is needed to be able to start, which is the second phase of inflammation, that is the one where we have the switch of these inflammatory cells toward pro-regenerative cells. So we go from the Th1 response to a Th2 to a T regulatory response in a level of monocytes from an M1 to an M2, again, pro-regenerative response. And actually what is interesting, we have also that these inflammatory cells and these inflammatory cytokines are directly working on the myogenic precursors. So, and we have the fibroblast-associated cells that are going to actually do a differentiation. So altogether, whenever there is a trauma, inflammation is the good response that is divided in a phase where we have an increase in inflammation, and then in a phase that is the so-called resolutive inflammation. And this is going to allow the regeneration of the tissue. But what happened during age? Unfortunately, many things are changing, and one of these is also our immune system. That is changing in terms of number of cells and in terms of functionality. This at the level of the stem cell level, in the bone marrow, but also in the adaptive immune system and even in the innate immune system. So the aging is going to make an immune system not perfect. And as we know, aging at the level of muscle is going to happen a few changes that are relevant for what is the so-called sarcopenia. And it's interesting that it's not that the immune senescence and the sarcopenia are simply two independent events of the aging, but actually it's been demonstrated there are a lot of connection, and seems that the skeletal muscle is actually one of the regulators, both in the degeneration of the muscle, in the sarcopenia, but also in the immune system. So all this together is making to say, okay, so unfortunately, when we are in a case where the famous trauma that I told you at the beginning is not going to happen in a healthy person, but is going to happen in an aged person, like in the patients that are considered in the HIPGEN project, or if we have a chronic inflammation, actually what is going on is that we do not have regeneration of the tissue, but we have a continuous degeneration when whatever is going to try to repair, it ends up in a muscle fibrosis. So we have to work now in this scenario, but knowing very well what is going on in the normal, let's say, recovery of a trauma. So here comes placenta, here comes the perinatal tissue-derived cells, and I like to say that placenta is an organ where there is both the fetal and maternal side. There are different types of cells that have, I would say, a great similarity in the action. Of course, we are concentrated here on the PLX pad, where we have already heard their origin is more from the maternal side of placenta. But I invite to consider placenta as an important organ from where we can take cells for tissue regeneration. And why? Why? Because we have been demonstrated that these cells are releasing factors. And these factors have different potentiality. But the one on which I'm focusing more, because it's the one that I pointed and highlighted as the key player at the beginning, is the immune modulation. So as I said to you, whenever we have an injury, we have acute inflammation. Normally, if we are healthy, it goes to resolution of inflammation and tissue regeneration. But if we have chronic inflammation, or we have somehow the tissue is trying to repair, but not in the optimal condition, we are going to have chronic inflammation, degeneration, with then fibrosis. So what we would like to do is to be able to block some of these arrows that goes toward the negative part of the pathway, and instead to bring it to go to the phase of resolution of inflammation. And this is actually what we demonstrate that placenta-derived cells are able to do. So they can participate in the muscle regeneration by modulating the inflammatory response. And I'm going to show you some data to prove whatever I'm saying now. So as we can see, we have that whenever we have the peripheral blood mononuclear cells that are activated, and so here they are, unfortunately. Something is the slide projected is not going very well, but so we do, as probably you can see, or you can see in some of our published data, what placenta-derived cells are able to down-regulate the inflammatory response in a dose-dependent manner, and are able to do it in different types of cells, on T cells, but also on monocytes, macrophages. So it's evident the immunomodulatory effect that PLX-PAD do have. And we have been trying to characterize, considering that the patients, we are going to talk about a population that is an elderly population, we wanted to see, is there any difference between the capacity of placenta cells to modulate in the young or in the elderly? And actually, we could see that these cells are going to are able to modulate any type of activated T cells, doesn't matter if they are in the young or in the elderly. So this is, of course, make us to say, well, this even more is a strong suggestion about the benefit that this PLX-PAD could have in our patient. So not only they down-regulate an inflammatory response, but what I think is even more interesting is that they are up-regulating a T-regulatory response. And also, as I said, relevant in the famous slide that I told you at the beginning, we have T cells, but we have the monocyte compartment. And once again, both in elderly or in young control, we're talking about control group that have been tested, so, we do have the capacity of these cells to make the switch from an M1 to an M2, and the M2 macrophages that are the ones that are inducing regeneration. So in conclusion, and more data will be presented about all the samples that we receive, including the patient, even though we do not know the association of the patients and the outcome of them. But clearly we demonstrated that the PLX-PAD have an immunomodulatory potential, and this immunomodulatory potential, what is doing is going to make the scenario of the inflammatory degenerative processes into an immunological balance. And this immunological balance is going to allow tissue regeneration. At least is one of the mechanisms, and we will hear with the next presentation about the second mechanism. But this is relevant, at least is required to allow even the second mechanism that as we described, because if we do keep having an inflammatory condition, we will never be able to have any type of tissue regeneration, no matter which type of cells then are going to be used. So I would say this was the rationale, and this is the outcome of this study. I always like to say that placenta looks like a tree, so the tree of life, as we like to define. This gives me the possibility again to thank you, the consortium, because this collaboration was great, and particularly the people of my lab that are here, Antonietta Cellini, that is the research coordinator, Andrea Papait, Elsa Vertua, and Marta Magatti, and mainly Andrea and Elsa did the majority of the work. So thank you very much, and thank you for attention.
Thank you. Most often question asked in online meetings is, can you see my slides and can you hear me? Okay, so nobody said no, so I guess you hear me. So when I will start. Thank you, Gabriela, for giving me a direct link. So it's my pleasure to present the second part of this work package 4. With focus on the systematic investigation of the beneficial effect of PLEX PAT cells on the cellular function of human skeletal muscle myoblasts. As Ornella said, while the Italian side focused on the direct immune modulatory effect of PLEX cells on PBMCs from elderly and young patients, we investigated here the direct effects of PLEX cells on muscle. To mimic the skeletal muscle healing in vitro, we used two different sources of skeletal muscle myoblasts. The first source was commercially available myoblasts from young, healthy donors, which we acquired from Lonza. And the second source, we used skeletal muscle myoblasts that we directly isolated from HIPGEN patients. For the later, we established a protocol that allows us to isolate these cells from very small muscle biopsies of patients, which are usually obtained during surgical care. In a first step of isolation, the muscle myoblasts were separated from myofibroblasts, which are only highly abundant in the tissue, based on their differential HIPGEN. Currently, the myoblasts were expanded in vitro for a short passage and then frozen and stored for the subsequent in vitro assays. Following this protocol, we obtained a relatively poor population of CD82 positive human skeletal muscle pre-myoblasts from the biopsies, and we could also validate that similar to the commercial available cells, these cells, at least in early passages, retain their ability to fuse into myofibers in vitro. In different in vitro assays, we then tested the functional behavior of these cells in response to the conditioned media of PLEX cells. These cellular functions include the increased resistance of the muscle progenitor cells to apoptosis, their proliferation capacity, their ability to migrate to the sites of injury, as well as their potential to differentiate or to fuse into muscle fibers. Our hypothesis was that PLEX PAT cells enhance muscle regeneration by directly modulating the myoblast function, which is highly essential for the cascade leading to successful healing after acute trauma. In line with our hypothesis, we found that primary myoblasts from young and elderly patients exhibit improved survival and proliferation under challenging conditions. Moreover, employing a scratch wound healing assay that mimics tissue disruption after injury, we found that the conditioned media of PLEX PAT cells significantly improves the migration speed of the myoblasts. Our second hypothesis assumes that PLEX PAT cells enhances the muscle regeneration not only via the direct effect on the muscle myoblast function, but also via indirect effects by modulating the injury environment. So at this point, both parts of work package 4 comes together. Just as a short reminder, as Ornella already pointed out, muscle healing largely follows the general concept of wound healing and starts with a hematoma formation and an initial pro-inflammatory response. This inflammatory phase is important to activate the progenitor cells and trigger their proliferation. However, as Ornella said, the timely resolution of this acute inflammation by an anti-inflammatory phase is crucial to enable subsequent healing steps and foster scarless regeneration. To analyze the combined effect of immune cells and PLEX PAT cells on the human skeletal muscle myoblasts, we isolated first PBMCs, as Ornella said, from each patient recruited in Berlin, and sent them to Italy. As mentioned in the previous talk, our partners in Italy investigated the immune modulatory capacity of P-Lex pad cells on the isolated PBMCs. And we in Berlin subsequently used the resulting condition media from these experiments to test the functional consequences of this immune modulation on the muscle cells. In line with the pro-inflammatory environment provided by the activated immune cells, we found that conditioned media from PBMCs alone resulted in an increased proliferation of a myoblast. In contrast, we found that in the presence of P-Lex pad cells, the migration of the myoblasts were significantly enhanced, but this was independent from the cell source, and we obtained similar results for the cells from young and healthy patients. Perhaps more importantly is that the co-culturing of PBMCs with the P-Lex pad cells not only reduced the immune cell activation, but also significantly reduced the inhibitory effect of the conditioned media from the PBMCs on the muscle cell differentiation. This indicates that P-Lex pad cells support the time resolution of acute inflammation and enable the initiation of tissue regeneration. Finally, we examined the alteration in the molecular composition of a conditioned media of activated PBMCs resulting from the co-culture with the P-Lex pad cells. We found that the co-cultivation of activated PBMCs with P-Lex pad cells, here in blue, significantly reduced the level of pro-inflammatory cytokines such as TNF-alpha and interferon gamma compared to the monoculture of activated PBMCs alone, that is shown in orange. Accordingly, we found that adding both cytokines to the myoblast culture negatively affects their differentiation, that we also observed for the conditioned media. And regardless whether these cytokines were added to the cell cultures alone or in combination, as shown here, we observed a marked decrease in myofiber formation. This once again underlines the importance of a timely switch from a pro to an anti-inflammatory phase to allow the full recovery of the injured tissue. In summary, P-Lex cells secrete different growth factors and cytokine patterns depending on their specific stimulation, which directly affects the functional behavior of myoblasts. The primary mechanism of action seems to derive from the immune modulatory properties, which allow the timely resolution of the initial pro-inflammatory phase and facilitates a proper transition to the subsequent healing phases in which the original tissue structure and function is restored. Thank you very much.
Yeah, thanks a lot, Anela and Sven. The mechanism of action studies are super vital in this consortium, and they show us how actually the cells work. And all these data shows us that this is not, and this is very specific for cell therapy, and if you compare to small molecules, for example, that we always have a differentiated and a coordinated mechanism of action. And this is nicely shown by your work package, and I thank you for that. Now I want to announce the last speaker of this session. This is Thomas Klein from Be the Partner. He will speak about the Be the Partner platform, which is a patient involvement platform. This patient involvement platform has been designed specific for clinical trials and is a very nice place actually for patients to connect with trials. And he will also talk a bit about learned lessons from the HIPGEN trial here. Thomas, please.
Hi, everyone. So, yeah, full disclosure, I'm not Thomas Klein. Unfortunately, he's been called away on some last-minute urgent business, so he had to attend some other meetings. So I'll just be running through his presentation for you all to give you an idea about what Be the Partner has been involved in during the project and, yeah, the different things that we've learned and our experiences throughout the HIPGEN project. So that's me in the left corner over there, I'm Timothy Bawadi. I'm the Director of Marketing and Be the Partner. Top left, that's Thomas Klein, our MIA CEO. He's based between Berlin and the States. I'm based in Berlin. Ryan, our CTO, is also based in the States, as is Lisa. And Andreas, our Director of Technology, and Berger, our legal counsel, are all based in Berlin as well. So Be the Partner, if you don't know what it is, Tobias just gave a short bit of info about it. It's what we like to call a patient engagement platform. And so the purpose of the platform is to facilitate anonymized communication between the trial site and the trial patients before, during, and after a clinical trial. So this has been shown to have all kinds of positive effects on things like recruitment for future trials, also patient retention and patient adherence to trial protocols. So what you see here is the login portal. The platform is available online at bethepartner.com. You can log in over there. It's a very simple login process: email address, password, select your study. You see the German version here. The platform is available in, I think, 26 languages at the last check. So it can be localized to all kinds of different trials and different specific needs. So what you have here is also an example of some of the content that we've provided for the HIPGEN trial. So at the beginning of all trials for which the platform is being used, we provide a welcome note, which thanks the participants for registering for the platform and for also being involved in the trial, and lets them know that their contribution will go a long way to bringing the field forward, so on and so forth. We also provide some information about the study, as you see here in the center with this HIPGEN slide. And we have some different languages here. This image here with the jumping birds is a reminder about mobility exercises, which can help to facilitate the healing process. There's also a reminder here for an upcoming site visit for the patient. And another feature that we actually provide is the ability for lab results to be shared with patients when this fits within the trial protocol. So speaking a bit about our experiences in the trial and our engagement and the uptake, overall, the patient uptake was extremely low throughout the project. There's a few different reasons for this, which we figured out, which we'll get into shortly. So in total, only 4 patients sent in an authorization form, and there were no full account activations. As some of the previous speakers have alluded to, we were also affected, of course, by the COVID pandemic, and this caused some delays and disruptions in the enrollment process, and also changes in the priorities of ourselves and also of the trial site, which of course makes sense. So we didn't just sit on our laurels and allow this to happen. Of course, we took various steps to try to increase the patient uptake throughout the trial. Initially, the platform was only offered at the first hospitalization visit, but we made it so that this could be offered throughout the trial at different visits and different points, which provided more opportunity, of course, for patients to get on the platform. It was also offered to patients that had already left the trial for whatever reason or had completed the trial. This wasn't a simple undertaking. We had to edit a lot of our patient-facing documents, so that's something that we undertook for these patients as well. One step rather that we thought would have a big impact was the integration of caregivers into the registration and account management process for the trial patients. So for the HIPGEN trial, as you're all aware, the patient population is very old. And so our platform is a computer-based platform. So of course, a level of computer literacy is required to actually use it. So the integration of caregivers was to try to maybe let the less computer literate patients be able to give control of their account to a trusted relative or even to the study nurse to actually manage that for them. So we thought this would have a bigger impact than it did. Unfortunately, in this instance, it didn't have that much of an impact, but the reasoning we still believe was very solid. We also provided improved support for the Central European time zone for patients that were registering. This allowed real-time support from Be the Partner staff for trial staff and also for patients to get registered on the platform. We also tried to expand the deployment of the platform during the trial with steps to obtain approval in the UK, in Denmark, and in Israel. Unfortunately, this didn't pan out for us. And lastly, we also had some additional site trainings that were offered to all the different trial sites, virtually and in person, But at the end of the day, we only did a couple of these, so the impact there also wasn't so great. So yeah, I always like the expression, every cloud has a silver lining. So of course, the deployment was not so successful within the HIPGEN context, but we still learned a lot of different things, which we already happily able to integrate into some different trials that we're involved in at the moment across Europe and also in some other countries as well. So what do we actually learn? So yeah, as we've said, the deployment was unsuccessful in the HIPGEN trial, despite the best efforts of the trial staff and the partner staff as well. The age of the patient was a significant stumbling block that we faced, and also the nature of the indication wasn't very facilitative towards the platform being highly used within this instance. So yeah, that was very problematic from the outset for us. Another issue that we faced was that because of the nature of the trial, we had no direct access to the patients, so we had a very limited ability to influence sign-ups ourselves. It was all dependent on third parties essentially. So one way that we figured that this can be improved is at the planning stages with more concrete and binding contracts for sites, which would put more imperative on them to promote the platform and also to facilitate further developments of the platform for the specific trial and getting information about what's needed and what isn't needed, what we could do better, so on and so forth. So as I said, all the experiences that we've gained from the HIPGEN trial have already been incorporated to some degree into the platform, and we're already hard at work using these in some other trials that we have currently underway across Europe. So yeah, in conclusion, there's obviously some work for us to do on the platform in terms of specific trials and the specific needs of some trials, which HIPGEN has showed us. One thing that we're actually actively working on right now is a mobile app to give people more direct and continuous access to the platform as well. And for the HIPGEN case, the trial showed us that the design of the platform should be more adapted to the needs of older people, for example, when it's called for, as it was in this case. Again, the point with the contracts, which I've said previously before, and there's also the fact that we have to contend with that the platform is probably not actually suited for all indications, as was the case here. So that's something that we're very aware of moving forward. So yeah, that's it. Thank you for your time. Thank you for listening.
Thank you, Timothy. Yeah, really, what we're doing here, as you see, is research. And research is development. Research is project management. Research is always unknown results. And this is not only in the core discipline of research, which means it's not only about the lab, it's also developing products for example, or which is a patient platform, for example. So also there can be the unexpected. Also there is the steering. There is also the management that you have to then change things, make them better. And I think this is what we are trying here, to make things better for our patients. And with this, I would like to thank all the contributors to this public session. I would like to also thank all the members of the consortium for their strong input. It is a great honor for me, or has been a great honor, to have been allowed to coordinate this consortium, and I'm really thankful for this task also. I thank all for their valuable contributions, and I'm also happy to close now this public session and to go into our internal discussions for this the rest of this long day. Thank you very much for everybody for listening.